Hi, my name is Dr. Ilana Gurevich, and I'm a board certified naturopathic gastroenterologist, naturopathic physician, and acupuncturist. Today, I'll be taking you through a talk focusing on bile acid diarrhea or bile acid malabsorption. We'll be looking at underlying causes, testing, and treatment. We're going to look at this from the perspective of a patient case. Meet Sandy. Sandy was a 40-year-old female who came in with a chronic diarrhea with over a 12-year history. This is a stock photo of a woman in her 30s because that's when Sandy started feeling sick. Her symptoms when she came into the clinic involved diarrhea 2 to 3 times a day with a Bristol stool chart bowel movement of anywhere from a 4 to a 7. She complained of daily bloating, daily belching, and nausea, and reported lots of undigested food within her stool. She also would experience pain rectally with really bad bouts of diarrhea episodes. She had urgency of bowel movements, and she would often report having streaking in the toilet bowl. There was not really that many upper GI symptoms, no reflux, no blood or mucus in the stool, and her symptoms were actually relatively inconsistent. 50% of the time, she'd have completely normal bowel movements. The other half of the time, she would have streaking and urgency, and she did have a history of bowel accidents. One of the things that was so frustrating for Sandy is she didn't know what was coming or going. She didn't know if it was going to be a completely normal bowel movement or a bowel accident bowel movement. When Sandy presented to the clinic, she had a history of having extensive workups offered by a variety of prior providers before seeing us. She had had multiple stool tests conducted, a variety of breath tests performed. She had attempted elimination diets, food allergy panels that were run, and then she followed that dietary recommendation. She had literally no improvement of symptoms. On top of that, she has a pretty significant surgical history. She had an emergency appendectomy 14 years prior to her first visit with us, and that was significant because the appendix had ruptured. Also, 12 years prior to the first visit, she had her gallbladder removed. If you ask Sandy what was the main trigger that worsened her diarrhea, she absolutely would report that it was the gallbladder being removed, and after that, everything started to get worse. Because she's seen so many different providers, she's tried so many different things before seeking treatment. She has adjusted her diet and done multiple elimination diets. She tried to rotate the different probiotics. She tried pharmaceutical treatment for bacterial overgrowth, herbal antimicrobial treatment, pharmaceutical antiparasitic treatment, and fiber. None of them showed any efficacy at improving her symptoms. At the end of Sandy's first intake, it became very obvious that she had never performed the correct stool test, and so we ordered a GI map. These are the results that came back after Sandy's first visit. This page is what I lovingly call the bad news page. I tell patients anything that comes up on this page, I often have to treat with pharmaceuticals. She didn't have anything at all come back on her bad news page. This is her H. pylori panel. This did not cross the threshold of being above 1 e to the third or 1 in 1,000. It also didn't show any virulence factors present. That could be potentially because the amount of H. pylori that's in there needs to be above 5 e to the second to be able to find virulence factors. We decided not to address any H. pylori at this time. As we come into looking at her commensal species, this is when a series of red flags really grossly emerges. The first red flag is the Escherichia species is low. The Escherichia species is a species that really causes biodiversity within the microbiome, and within this species, it also involves E. coli, as opposed both pathogenic and physiologic. When we see the Escherichia species increased or elevated, we see significantly healthier microbiomes. When it's decreased, what we see is a lack of diversity and more likelihood to see pathogens also within the stool. The other thing that she has that's low is the Enterobacter species. When we think about the Enterobacter species and we see it as a low finding, this is another way illustrating really low diversity within the GI. This species, when it's appropriately found within the microbiome, shows more robust diversity and just a generally healthier GI. The last thing that we see that there's non-detectable akkermansia. This is super important because akkermansia is one of the keystone species, and it plays a big role in mucin production for the colonocytes. The way I always describe this to patients is I always use the analogy of a house. There's the floor of your house. That's the colonocytes. That's you. Then there's the dirt. That's the microbiome. That's tons of bacteria. And then between the floor of your house and the dirt is the foundation. In the GI, that's the mucin layer. That's really important because just like you don't want the dirt coming into your house, you also don't want the microbiome touching your cells or your colonocytes because that leads to more inflammation and agitation of the tissue. Akkermansia is one of the keystone species that creates and uptakes that mucin layer, and the fact that it's lacking is kind of a red flag. And then we move down to the lower part of this section when we're looking at the Firmicutes and Bacteroides ratio. Her Firmicutes Bacteroides ratio is pretty astronomical. We don't often see this having this much difference between Bacteroides and Firmicutes. It's important because there is a connection with how the microbiome functions down the intestinal line and this ratio. When we see that Firmicutes is lower and Bacteroides is higher, not only are we thinking there's lower diversity, but we're also looking at most likely there's more fermentation of carbohydrates and starches because this is what Firmicutes predominantly eats. The other way of looking at this microbiome image is in the relationship of bile acids and bile salts and deconjugation. Both Escherichia species are important in deconjugating the bile salts. Escherichia is involved in the 7-alpha dehydroxylation pathway, and then Bacteroides and Firmicutes are both involved in deconjugation of bile salts and dehydroxylation of those salts. And if the levels are out of balance, we generally tend to see more pathology and worse symptoms. As we move into her dysbiotic bacteria, we see a couple of trends emerging. The first is that her Bacillus species is elevated. Bacillus is a spore-forming bacteria that can absolutely be commensal, but if it overgrows, it actually it's pretty resilient, and it can definitely change the microbiome, and it's on the more difficult side to eradicate. The next thing we see is the Enterococcus faecalis species also being elevated. Enterococcus faecalis is on its own not a pathogen, but depending on the level of overgrowth, what it does is it causes cohabitation with other pathogens and it makes them more pathogenic. It can also be commensal, but if it overgrows, then it becomes a problem. That's also true for Staph aureus and strep species. Both of them can be commensal, but if they overgrow, they kind of make the environment more hospitable to the bacteria than it is to the human they live in. Let's look quickly at the E here to dictate the overgrowth. So 3.11 e to the 6 for Bacillus, that's elevated from the 1.76 e to the 6, but it's not a log elevated. That can't actually be said for both the Enterococcus faecalis, the staph, or the strep. The Enterococcus faecalis normal is 1 e to the 4th. This is a whole log higher at 1.64 e to the 5th. That's also true for Staph aureus. Normal is below e to the 2nd. This is e to the 3rd. And strep, normal is below e to the 3rd, and she's trending at e to the 4th. So when we're looking at this, we're looking at the species that are overgrowing, but we're also looking at how much they're overgrowing to understand the intensity of her dysbiosis. As we move on to both her inflammatory autoimmune related bacteria and the fungal species, there wasn't really anything coming up here, so I didn't give it very much attention at all. She did not have any viral underlying causes show up in her GI map, and she did not have any parasites, protozoa, or worms show up, which were all within my differential because of her travel history, and it was nice to be able to put that marker aside. Getting to this portion of the exam, this is completely when her case began making sense. Seeing a steatocrit that is that elevated at 33 is pretty dramatic. especially within the context of a normal elastase. Elastase is a marker for pancreatic function, and anything over 500 we're happy with. We really will be satisfied with anything over 200, but there is some data that shows for optimal pancreatic function, higher is better. So her elastase and her pancreatic function look completely within normal ranges. However, her steatocrit is very high. Normal is less than 15. My preference is for it to be non-detectable, and she's at a 33, which is high. That means that the amount of fat that is coming into her stool is very significant, and it's the pancreas is doing its job. So what we see is a very clear way of differentiating between pancreatic insufficiency, which causes steatorrhea, and bile acid malabsorption, which causes steatorrhea because that steatocrit is elevated. Before we jump into the steatocrit that's elevated, I just really want to understand the other test that's on there, which is the fecal elastase or fecal elastase 1 enzyme. This is a stool test that's looking at exocrine pancreatic insufficiency. That is a condition that happens when the pancreas is unable to secrete the exocrine or the digestive hormones that are needed to transport enough enzymes to break down food in the intestine. The condition can be anywhere from mild to severe if it's present, and fecal elastase 1 is the diagnostic marker of choice. It also will go by the name of fecal elastase, pancreatic elastase, or pancreatic elastase 1. If we look back at Sandy's labs, her elastase is completely appropriate above 500, which means the pancreas is not the underlying cause of the steatocrit going elevated or the fecal fat. So let's dive into what is a steatocrit and why that matters to us. The first question to ask is, what is a steatocrit? A steatocrit is an acid steatocrit which assesses the fat content within the feces. The process that we're using to determine a steatocrit is the stool is diluted into an acid medium, and then it's placed in a hematocrit capillary tube where you can look at the percentage of fat in fecal matter within the sample, and you can calculate a number by that. Steatocrits are run on random stool samples, and no dietary changes are needed to assess this test. This is important because the other test options that we have are nowhere near as reliable. The gold standard for looking at fecal fat is what's known as a quantitative fecal fat stool test. The problem with this test is it is very, very difficult to get patient compliance. The breakdown of this test is you have a patient eating a very high fat diet. The diet should be at least 100 grams of fat per day, but not to exceed 150 grams of fat during that 3-day period. On top of that, they need to get 100 grams of protein and 180 grams of carbohydrates. This is a very, very difficult diet to achieve because of how rigid it is. Also, they have to collect their stool for the entire period to see how much fat is in their stool. While this is absolutely the gold standard, it is almost impossible to get a patient to comply with it. The other way of looking at fat in the stool is a qualitative fecal fat stool test. This is also a fecal fat test that a person does a collection and brings it to the lab, and then the laboratory technician makes a subjective call that's either 1 plus normal, 2 plus slight increase, or 3 plus definitive increase. The problem with a test like this is it's exceptionally subjective, and because of that, it's not very reproducible. One laboratory technician might see a stool sample that they consider normal, and another laboratory technician can consider it either slightly increased or definitive increase. It is not a reproducible marker. When we're looking at steatocrit versus our qualitative and quantitative fecal fats, we see that the steatocrit really falls in line pretty specifically towards the quantitative or more sensitive fecal fat test, the one that's looking at the quantity of fecal fats. The acid steatocrit on a random stool sample compared to 72-hour quantitative fecal fat has a sensitivity of 100% and a specificity of 90% and a positive predictive value of 90% for the detection of steatorrhea. In summary, when we're looking at all of our options for testing for fecal fat, steatocrit really comes up on top. It is very, very easy to do it. It's a random sample. You don't have to weigh a patient down with a very complicated diet. And also, it is as accurate as the quantitative fecal fat, which is the gold standard, but it's significantly easier for the patient to do. This is the test of choice for my patients to rule in or rule out bile acid malabsorption. Looking back at Sandy's digestion markers, we see that her elastase was within normal limits, but her steatocrit is really elevated. We've discussed why that matters as far as looking at steatocrit as a marker for bile acid malabsorption or steatorrhea. Let's a little bit dive into the physiology of bile acid malabsorption and what happens with it. And whenever we're looking at pathology, we always want to start with looking at physiology first. Looking back at physiology and the physiology of bile, what happens is bile acids are built in the liver. They then get shunted from the liver into the gallbladder for storage and to make the bile more potent. This is a similar process to when you make soup at home. You cook it down, it becomes more flavorful. The bile gets cooked down and becomes more potent at breaking down fats. When the intestine is exposed to dietary fats, the liver and the gallbladder will secrete the bile to process those fats, and then the bile will bond to the dietary fats to break them down in an attempt to digest them. The intestines will actually reabsorb about 95% of that bile, and it will be recycled for the next meal. The bile is highly absorbable, and that bile gets reabsorbed. However, there is a process of deconjugation of the bile salts that happens both in the liver and the gallbladder. It's important to remember that primary bile acids are different from secondary bile acids. Primary bile acids, cholic acid and cyanodeoxycholic acid, become conjugated in the liver by adding a glycine and a taurine molecule to it to increase water solubility. Then that will go to the microbiota, and bacterial enzymes will act to deconjugate those bile acids, producing free bile acids. The relationship between bile acids and the microbiome is bidirectional. So bile acids can shift and cause change to the microbiome, but also the microbiome will impact how primary to secondary conjugation happens or doesn't happen. Those primary bile acids, the cheloic acid will form deoxycheloic acid, and then chenodeoxycholic acid will form lithocholic acid. When the physiology of bile becomes dysfunctional, that's when we have issues. One of the issues that we can have is known as bile acid malabsorption or bile acid diarrhea. What happens with this is the body does not reabsorb 95% of that bile. It ends up entering the large intestine. And when it enters the large intestine, two things happen simultaneously. The first is the water will follow the fat. And so since there's an increased amount of fat attached to that bile, the intestine will flood with water. The second thing is those bile salts will activate peristalsis, or a huge contraction of the large intestine, and those two situations together make an intense watery diarrhea. This diarrhea episode generally is full of steatorrhea, or fat in the stool, and it happens very quickly and spontaneously. Not all watery diarrhea is bile acid malabsorption, but bile acid malabsorption is one of the causes of watery diarrhea that we often forget about. Symptoms of bile acid malabsorption can include watery diarrhea, urgent bowel movements, abdominal cramping, and also patients might have bloating and even nighttime bowel movements and bowel accidents. This brings us back to Sandy. And when we look at Sandy through the perspective of how to read a steatocrit, it becomes very obvious that her issue was bile acid malabsorption, and the secondary effects for that were the dysbiosis that we were seeing. So what we started to do with Sandy is treat her for bile acid malabsorption. One of the problems with bile acid malabsorption is that the testing is not robust enough to find it. Steatocrit gives us a very good insight, and at the moment it is the best test we have, but it doesn't exactly tell us what's happening with the microbiome. And so one of the ways we treat is to offer people treatments, assuming that it's a bile acid malabsorption, and then from there we see if the treatments work. Here's a small list of potential treatments. It's not exhaustive by any stretch of the imagination, but it is not a terrible place to start. The first place we start is lecithin. Lecithin is made from different food groups, either soy or egg or sunflowers, and what it does is it reduces the absorption of fat within the small intestine, and it helps it bind that fat so it never really enters the large intestine. Activated charcoal will bind to bile, preventing it from drawing up more water and preventing that bile from entering the large intestine to cause diarrhea. Pectins are also used to bind fat while it's passing through the intestine. And then tutka is an old Chinese remedy that has been used for thousands of years that shows a lot of efficacy with bile salts. Currently, we use it in a synthetic form. Originally in Chinese medicine, it was used from a bear. From a pharmaceutical perspective, we have a class of drugs called bile acid sequestrants. Those drugs basically you take them with food, and then they enter the small intestine and they bind with that bile, and so they don't let all of the water and the peristalsis activity happen when it hits the large intestine. They sequester that bile. Whenever we're having a pharmaceutical conversation, we always do have risks. The risk that usually comes with the bile acid sequestrants, the most consistent one, or the one that we worry the most about, is actually terrible constipation and fecal impaction, which could potentially lead to an obstruction. We also can have some issue absorbing fat-soluble vitamins, mainly because when we're binding the bile, the fat's not getting absorbed, and so we're not absorbing those nutrients either. And then we can have common reactions like abdominal pain, gas, bloating, nausea, and all of those other things. With Sandy, what we ended up doing is introducing bile acid support through the supplement model as opposed to the pharmaceutical model. She wasn't comfortable taking a pharmaceutical for the long term, and she wasn't comfortable about the possible side effects. So we introduced lecithin, sunflower lecithin for her. We also introduced probiotics to replace a lot of those key species that were missing in her GI map. And then we had a long discussion around fermented food. Fermented food is one of my core treatments that helps patients increase biodiversity within the microbiome. If we think about fermented food from a macro view, there really, up until the last 100 years, there really was not a single culture historically on the whole planet that didn't utilize fermentation as their main way of preserving food. That was really our only option before the 1940s, when we simultaneously developed refrigeration and antibiotics. After that, in the West, we waged a pretty significant war on bacteria in the microbiome. And really, in my experience, the only way to turn that around is to reintroduce fermented foods. Fermented foods are great to be utilized in a different variety of forms, not just focusing on one specific fermented food, but a variety of fermented food, and introduced throughout the day, not the more you can introduce it, the better. Sandy did really well with this treatment plan. We were able to have her comfortably reintroduce dietary fats. She was a little bit cautious initially, but then when we discussed what was really causing the bile acid malabsorption and the diarrhea, she slowly was willing to introduce foods, and now she has a pretty wide diet. Unfortunately, I have not been able to get Sandy off of the lecithin that she uses. She still needs that, but she really doesn't mind it as much because she can eat such a broad diet at this point. There are a subset of my patients that I absolutely can treat the underlying cause and the bile acid malabsorption for 3 to 6 months, and then they can have a resolution of their symptoms and not need digestive supports. But unfortunately, Sandy doesn't fall into that category. I hope you found this presentation helpful. Here are some references that I have if you guys are looking to do a little bit more of a deeper dive.